Now we have Dr. Umesh, head of Shankara Eye Hospitals, Bangalore. He will be talking to us about tackling astigmatism in cataract surgery, evidence-based.
Thank you, Dr. Ellen, for these wonderful topics and most practical-oriented topics this way. Um, Now, all of us know that astigmatic treatment is part and parcel now, especially because we have entered the zone of refractive cataract surgery. So, astigmatism correction makes important part of our practice profiles. So, what are the different modes here is, these are the different modes. One is intraocular lenses, that's the hallmark. Now you have flax, it uses the femtosecond technology for this. The only challenge is it's more costly. LRIs and PCRIs were always there, but because of regression and unpredictability, it somehow is losing its credibility. And post-surgery custom ablation is one option that we have for the unsatisfied patients. And the emerging technology now is the intraoperative aberrometry, which does the real-time aphakic and pseudophakic refraction and gives feedback. Now, as my previous speakers have all re-emphasized and emphasized, for any astigmatic correction, two things are very important. One is the amount of cylinder, the value of the cylinder, and the axis. These two are important. And invariably, we have all these equipments. In my thing, I always see a variation in each of these. So that is where you have to use your trial, your error, your validation, your calibration, and ultimately your experiences, and try to find out which is the best for you amongst the available resources. The best is you take two readings of different technologies. If you have a swept source, you do also topo with a sham plug, or the AR, which is a different technology, and try to get. I somehow I have come to a conclusion that the cylinder amount of value of cylinder, if between the two is less than 10%, you take. The second is the axis, because I go for the automated topcons because I do refractive surgeries, I get good results with that. So I prefer the axis there. So I believe all of you should try to do some trial error from your perspective of the data that you get, do some data analysis, and can come to some conclusions. And of course, posterior corneal aneurysm now is imperative that we use it. And previous speaker has already told that undercorrection, overcorrection, especially with the rules and against the rules, we are part of it. Now, this portion, this 0.3 up to 0.3, it is there. There are some cases where you get minus 0.3 or 0.4 or plus 0.4, 0.5. There you have to make that necessary corrections. Otherwise, if you tick the box PCA, it will take into consideration. And the most important is the marking. Once you know what is the axis, once you know what is the amount of cylinder, comes the marking, and that is where most of the deviations occur for us. And there are many things here. One is standard markers, the bubble markers, and yes, all of us have been doing it. We have our own variations, our own standard deviations, but again you have to develop your own. Let us discuss some difference between the image guided and the manual markers. The bubble marker effectively is better because you can at least see the orientation. There are many advanced markers also, manual markers also. But the disadvantages, yes, there are some disadvantages here. Smudging, especially when you're using the ink. The thick ink smudging often leads to 5. That is our threshold. The 5 degrees is our threshold. That is where you end up. So you have to ensure. Now thermal dot mark ink marks are there to prevent smudging, and or some of us, most of us, at least I have now stopped using the inks. We use the 27 gauge needle to do the marking. And image guided techniques, they use the Callisto and the Virion. They are the most commonly available, expensive, but they are now help us to avoid these things, the errors there. But it also has its own problems and disadvantages. People who use it will definitely know. And the eye tracker disengagement during surgery, it requires re-registration. That becomes very problematic. What is 5-minute surgery will become a 10-minute surgery there. Conjunctival chemosis, bleeding interfere with intraoperative registration. Registration may also be not possible, especially the patients are uncooperative, and most importantly, the high financial costs. So each of them have their own pros and cons, and of course, the future is the intraoperative aberrometry, the ORA. At some point, we will all have that, and that is the principle. Now, let us do what is the comparison, because we have to come to a conclusion whether manual marking, or because that's the most important aspect, manual marking or digital marking. So Shirish, my friend Shirish Kudavur, he did a study between manual and he said the results were comparable. Ding and the latest one, he has compared between the both, and he said that he made a small variation on table using a 26 gauge needle directly at the axis, not the horizontal or vertical, direct the axis, and he said that improvised his outcomes, and the manual and the digital marking to some extent matched, and there was no significant difference, especially when they went for the mean deviation less than 5 degrees. Both were well within less than 5 degrees. So, very well accepted. Course B also was there. And the one which is TTL sir, comparative evaluation of the 3-step marking with the conventional, with the image guided surgeries, he also showed that the limitation of the study obviously was that they didn't take into consideration, they only took the rotation, not the residual refractive error. But even if you look at the rotation stability, it was comparable. So I guess people who want to do marking, if some experience, some trial, if you are able to get the correct ones, I think you will get more or less good results comparable to the image guided lens. And what I do is this, I use a slit lamp slit. Most important, ensure the patient is aligned vertically here, the patient is aligned vertical, and the split is done horizontally, then you know that you are perfect 90. Now I also do the vertical axis similarly. The difference here, you see the smudging between the 90 with this one and the smudging occurs, and so what I do is mark it and then do the smudging, or on table put a blue, so visibility becomes much effective. And intraoperative axis, obviously, once you do that, you do the intraoperative. Even in intraoperative also I use the 26 gauge needle, and that gives me more less than 5 degrees of efficiency there. And rotation, on table rotation. Anybody doing torics, I believe that this is a very good paper. All of you must go through this paper. It's a comparison of the rotation stability of 2 toric intraocular lenses. The main ones, the J&J, Technis, and the Acrisoft, done by Dave Chang. It was the largest series, 12,073, and very beautiful key takeaways that he has given here. First is the thorough irrigation aspiration to remove all OVD. Yes, all of us emphasize that, including below the IOL haptic and capsular pharyngesis, most important around the haptics. So these 2 things, because most of us just tap and remove, go behind the IOL, go beyond the capsular pharyngesis and around the haptics. Proper inflation of the anterior chamber to ensure the TIOL rests on posterior capsule. I think my previous speaker told putting air bubble also, and that also aligns with that. Greater axial length, and with the rule astigmatism more likely to rotate, especially greater axial because the bag is larger. So nowadays I am using rings also, just to prevent rotation. Maximum incidence of rotation occurs within the first hour of surgery. So what they recommend is limit the patient activity to immediate post-operative period. They ask them to, especially if you are doing topical, patch them, ask them to lie down, not move for 1 hour, to prevent post-operative, because maximum rotation occurs within the first hour of surgery. Rotation stability depends upon material, width, stickiness, design of haptics. They said that the Technis IOL rotated more than Acrisoft, and because of that the Technis J&J came out with a modification of the haptic with those sandblasted haptics, and now I believe they are also doing well. I think these are all the feedbacks that we get from them. And in case of repositioning, if there is any rotation and you want to reposition, they recommend delay the procedure for at least 2 weeks, as capsular contraction will occur and it will prevent re-rotation, because further re-rotation, and use BSS on a cannula to form anterior chamber instead of OVD during the procedure. Just to emphasize, cleaning the OVD behind the IOL in the capsular pharyngees, and to me, I see depend on the thickness of the IOL, the Alcon types where the refractive index is on the higher side and thin, it opens up faster, where the techniques opens up slower. So wait for the haptics to completely open, spend 1 or 2 times, then rotate and then stabilize the patient. See, that would be my key takeaway to ensure that you get good successes. Thank you.
Thank you, Dr. Umesh. That was a very good talk. Any idea about the cheaper, well, I call upon Dr. Subhash Prasad sir to get his slides done. Any experience with the cheaper non-marking devices that are available in the market? I just have one, that's why I asked.
Yeah, the slit lamp, the camera based.
Camera
Yeah, I
based.
don't have any experience, but I'm very happy with this slit marking with a 26 needle, both horizontal and vertical. Just the one thing is make sure that the patient alignment is correct. Sometimes what happens, patients tilt their head and you get a slight 5-degree variation. So make sure the patient holds is comfortable, holds and his head straight, and then do the marking. I think there you can manage some of the.
I have one slight variation. So usually if the axis is say 160 or 170 or 180, I always try to do the surgery on the steep axis. Say if it is 160, I mark the 160 axis, I do the surgery on the 160 axis, and when we do that, the placement of IOL will also be on the 160 axis, because there is no difference in astigmatism created by our incision. So I don't need to mark 0, 180 and then the vertical axis. I just need to mark only the axis on which the IOL is placed. On the same axis, I do the cataract surgery, and the lens will be placed on the same axis. So that's how it will be.
Dr. Arvind, I also do the same thing.
Yeah,
the
that is
only
what
problem happens when it is nasal. So nasal we don't go ahead. So what I do in those cases, go a little bit temporal and create the side port there. So that side port is going to guide us. But what OCCI, something like that. So do that and do it. Anyway, there is a what I wanted to mention. An Indian innovation is there. There are a lot of almost 3 Indian innovations which are your smartphone based, which can be used in the OPD. Jetva marker, Patwardhan marker, and recently Dr. Shishir marker. This last one, what I want to tell, he has extended it and taken it inside the OT. For a very small amount, you can get that device and use it in the OT. Despite these 3 things being available, single mark is required. You can mark it anywhere, but it will calculate what that axis is. Need not be 0, 180. You can mark it anywhere, and from there, your phone will calculate what is the real axis, and it will show you inside the OT. Beautiful one. It's available in 3D Medisys. You can see it. No personal, financial commitments from my side, but I was really impressed with that when I saw that.
Yeah,
Yeah, even
the more you use, you yourself will get more ideas.
even Dr. Swapnil Kothari, one of my
Swapnil,
friends.
sorry, not
Kothari.
Shishir. Dr. Swapnil Kothari.
Swapnil Kothari, yeah, I use that, and that doesn't cost much also, because not usually we just go with the slit lamp marking as 0 and 180. We mark it with the this blue gentian blue or anything. We send it to the server. That server will calculate and tell us whether we are marked perfectly or not. If it is -3, like it is less 3, we just have to keep on the table on the same axis which he has provided, just for the accuracy or reconfirmation. And believe me, it's bang on, and it's free of cost online.
So, yeah, it's
Free of cost
online. But if you want the inside the OT marker,
Marker.
that is
You have
slightly,
just like a video. He's coming with the.
it's already come out. It's there.
Yeah.
It's there.
Yes.
Yeah, I think innovation. Otherwise, we can't keep spending money on.
We
these
can't go
things.
for every time Virion and other things. We can't afford that.